Dr. Hadjipanayis. Great. Thank you very much, Dr. Hadjipanayis. Dr. Hadjipanayis is a professor and vice chair at the famous Pittsburgh Department of Neurosurgery. He is also the current chair of the brain tumor section of the CNS and AANS. It's a real honor to have him to give us this lecture on stereotactic radiosurgery for brain tumors. Thank you, sir.
Thank you. Good morning, good afternoon, everybody, and thank you, Dr. Dufo, for letting me go here. I wanted to give a talk. I was asked to give a talk about radiosurgery for brain tumors, and it's quite a large amount of information to go over. So hopefully I'll do us justice by trying to summarize some of the key aspects. I direct our Center for Image-Guided Neurosurgery here at the University of Pittsburgh. I perform radiosurgery, I also perform open surgery, and but really happy to share some of our experience and a large number of outcome studies that have come out of our center and institution here at the University of Pittsburgh. Can you see my presentation okay?
Yes, absolutely. Yes, thanks.
Okay, great. So, I'm going to start out just by throwing 3 cases to the audience here, just to get them to think a little bit. We have neurosurgeons from different backgrounds in different countries that, I thought maybe this would be kind of a nice way to start this out. So this is case 1, a petroclival meningioma. This is a 65-year-old female with right-sided trigeminal neuropathy. And, I listed some potential avenues for treatment options. And 1 is observation. 2 is, performing a Charents-Petras resection of this. 3, endoscopic and a nasal resection. 4, fractionated radiation therapy. And 5, radiosurgery. So we'll come back to this at the end of the presentation, but I just wanted to plant the seed now for the audience to think about these kind of 3 index cases that, I think radiosurgery will be discussed in the context of other options. Case number 2 of vestibular schwannoma, Cus grade 4, indenting the brain stem, 76-year-old, with, sensory neural hearing loss on that side, no facial paresis or trigeminal symptoms. Again, what treatment options? Observation, performing a retromastoid approach for this, translab resection, fractionated, again, radiation therapy, and then lastly, SRS. And then index case number 3, a solitary brain met in a 52-year-old. You could see here kind of a right lobar metastasis, non-small cell lung carcinoma. Would you give steroids? Would you give immunotherapy? Would you do a craniotomy and resect this? Would you perform fractionated whole brain radiation therapy or a radiosurgery? So when we talk about radiosurgery, we're quite fortunate in that this field came to birth really through a neurosurgical armamentarium and view. And the neurosurgeon, who we'll discuss shortly, really kind of provided this new option that, in my opinion, provided a innovative treatment to perform, treatment of tumors that, in other words, other treatment options were difficult to approach, especially with the skull-based tumors that we just went through. And anytime a new technology is proposed, it's disruptive, right? I mean, how does this technology really last in the eyes of the users of this technology? So when you look at an innovation cycle, you can see that there's standard practice, and then there are unmet needs, unmet gaps that need to be filled. And then that innovation kind of comes around, and radiosurgery is one of them, especially with the Gamma knife. And then that's met with skepticism, right? Why would you perform Gamma knife? We've been doing surgical resection for certain tumors for, quite some time. And then what we do is we provide evidence, outcome studies that really show that this treatment option has provided long-lasting effects and treatment outcomes that could be equivalent or superior than our standard approaches. And then it becomes standard practice. So I think that's kind of the cycle we've seen with radiosurgery. And if you look at it as a disruptive innovation in neurosurgery, its use has skyrocketed pretty much for every indication that we'll discuss today. We won't go into AVMs, we won't go into trigeminal neuralgia or thalamotomies for essential tremor. But you could see in this graph here that for malignant benign tumors, for skull-based tumors, et cetera, this has really taken off in much of the world, which is quite interesting and singular. This was a picture that I got from Dr. Lunsford. He's my mentor, showing kind of the birth of radiosurgery. This is a prototype for the Lexel frame using a orthovoltage dental X-ray tube to treat this patient with trigeminal neuralgia. And you can see there, this was 1951, and two patients were treated in the early 50s, and they had pain relief because of that treatment at that time. Well, Lars Lexell and Borge Larsen were really kind of the two figures that allowed gamma knife radiosurgery to take hold and really launch into the neurosurgical arena. And of all the people who've gotten Nobel Prizes, of course, Lars Lexell passed away, but the contributions that gamma knife has made throughout the world for our patients has been really truly spectacular. So at UPMC, we were the first to start with radiosurgery in 1987 in the United States. Sweden had actually the first gamma knife, as I mentioned, but we were the first in North America to have the gamma knife. And this has been such a key hallmark of our program here. And you can see here the evolution of the gamma knife from the U unit in 1987 all the way to the Esprit, which we now have in 2025. We got it in 2024. But you can see here, it's been quite an interesting technological development through the decades here, now 38 years later. Our numbers, we've treated over 19,000. This was as of August 2024 in the summer. Much of our treatments are metastatic disease, but you can see here we've treated a fair number of meningiomas, schwannomas, gliomas, pituitary adenomas, and some other tumors that are much less common, and also have performed radiosurgery for a large number of vascular malformations and trigeminal neuralgia through the last 37 years. Overall, though, you can see in the world, the gamma knife has been quite popular with over 1.5 million patients treated. So it's quite the impact in a variety of neurosurgical disorders. We're going to kind of jump into this. I really wanted to, again, highlight some of the game changers that I think radiosurgery, specifically with the gamma knife, have allowed us to advance in. And one of those is schwannoma radiosurgery, also known as acoustic neuromas. We've done almost 3,000, we've treated almost 3,000 patients with schwannomas, not only acoustic neuromas, but trigeminal, jugular, facial. And, we've been able to treat those in a primary fashion in many cases. This is a picture I got from Dr. Lunsford. This is a 93-year-old with a vestibular schwannoma who underwent his treatment, did quite well for, a tumor that in a younger patient probably could have been resected quite safely, but in a 93-year-old, probably not a patient we want to take to the operating room for an extended skull-based procedure. But we've really understood with the number of patients we've treated, kind of some of the nuances with vestibular schwannomas in terms of, whether we should wait on treatment, whether the size impacts outcomes, hearing preservation. These are all things that our center has led the way in terms of defining the timing and whether, the larger tumors can be treated in a number of studies. I mean, here you can see just case examples, person who's 69, with really good long-term outcome tumor control rates with vestibular schwannomas. We now have data that's now past 20 years, over 25 years. We're soon going to be putting out a paper looking at our 30-year outcomes. So this is, kind of an interesting phenomenon where we now have several decades worth of patient outcomes. And the long-term tumor control for these types of tumors is quite impressive. The fact that cystic tumors do not respond well to radiosurgery is it's a myth. And we actually do treat cystic vestibular schwannomas very commonly in our group, and they respond quite nicely. You can see here that with the homogeneous versus microcystic versus macrocystic, they do continue to respond quite well with radiosurgery. And when you look at the volumetric response of these tumors with time based on their Coos status, even the grade 3s and 4s respond quite nicely in terms of decrease in volumetric size of the tumor after radiosurgery treatment. In terms of hearing preservation, we are very open about advocating for early radiosurgery in terms of improving hearing preservation in our patients. We think that hearing preservation rates are quite high with the Gamma knife. There are studies showing that hearing preservations later are much lower with treatment. So I think, treating these patients early, we do have outcome studies that are able to kind of confirm that those patients do have a higher preservation of hearing. So some of the principles that, in terms of schwannoma radiosurgery, we don't wait. We actually treat these tumors early because they do grow consistently on an annual basis, and hearing preservation worsens the longer we wait. We do recommend, obviously, microsurgery for patients with symptomatic mass effect. But if you look at our numbers in terms of radiosurgery up front, the progression-free survival is quite high at 10 years. And our facial neuropathy rates, it's actually less than 1%. Here it says 1.1%. So, it's interesting that, when we see neurosurgeons in our center with schwannomas, they always want to get radiosurgery. It's a quite common phenomenon because of these high outcome rates. And in fact, if you look at our practice through the years, we do treat most of our vestibular schwannomas with radiosurgery now, based on some of the results of our patients we've treated over the last 3 decades. So another game changer are meningiomas. We've treated almost 3,000 meningioma patients, and the skull-based meningioma patients are the ones we really take pride in treating. These can be quite difficult, the petroclival meningiomas, the cavernous sinus meningiomas, where surgery really is associated with a lot of deficits. Radiosurgery is really not meant for large meningiomas. These should be resected. I think that is pretty obvious. Patients with symptomatic mass effect and, optic nerve sheath tumors, those are not radiosurgery candidates. But, I think an elderly patient with, a small to medium-sized tumor that's growing, I think, those types of patients are very easy to treat with radiosurgery with very minimal side effects in terms of adverse radiation effect or radiation necrosis. We've been able to treat a number of elderly patients quite effectively with a variety of meningiomas, both lobar, skull base, and other locations. When we look at the skull base meningioma group, we do have long-term tumor growth prevention, and the symptoms that we see are low risk of symptoms, and patients can go right back to work. I mean, the next day if they need to. And I mean, you can look here at this, clival meningioma. These are not easy tumors to resect, and we can control them quite nicely with radiosurgery with minimal to no side effects. Cavernous sinus meningiomas, I think this is probably should be a standard of care now in terms of treatment of patients. I mean, we should not be, exploring the cavernous sinus surgically when Gamma knife is such an effective tool with minimal to no side effects in terms of cranial neuropathies. Adjuvant type radiosurgery is quite effective too for parasagittal meningiomas involving the sinus. We have a large number of patients where they've done quite well in long-term fashion after treatment of these residual tumors involving the sinus. We've published a lot of papers, both short-term and long-term outcomes for these types of tumors, and we have a paper that'll be hopefully coming out in the near future where we detail our our treatment of close to 2,000 meningiomas in terms of long-term outcomes of these patients. When you look at the grading of these meningiomas, obviously the grade 1 and 2 meningiomas respond most effectively, but the higher grade meningiomas, the grade 3s, and some of the grade 2s just do not respond as well. And those are the tumors that we need help with chemotherapy. We can make some differences in treatment of these tumors, but overall, these need to be treated in adjuvant fashion. They recur quite quickly, and we've advocated radiation therapy as well in these certain situations. Gamma knife for these types of tumors, which usually are pretty invasive and large, likely require external beam radiation therapy. But gamma knife can be a tool for these types of tumors as well, especially the grade 2s. So the cranial nerve outcomes after radiosurgery for skull-based meningiomas are quite good. You can see here that we've treated a fair number of petroclival meningiomas, cavernous sinus meningiomas, CP angle meningiomas, and I think I showed this slide already. When we look at some of the patients with small to medium meningiomas, you can see that the Simpson grade 1 resection versus gamma knife radiosurgery, there's really no difference in terms of 7-year outcome studies, and even resection of a grade 2 Simpson grade 2 meningioma versus radiosurgery, quite similar. So very effective treatment option that we really need to keep in mind for these tumors. And after 30 years of meningioma radiosurgery, I mean, we've learned a lot, and that this is quite an effective treatment with low morbidity, rapid return of function. And I think for patients with smaller tumors that are growing in critical locations, where surgery just poses undue risk for the patient, this should be the treatment of choice. And I think we've provided evidence to support that through the years. There's now some studies looking at single versus fractionated radiosurgery now with the new gamma knife models that can perform this. And I think that's still a treatment pathway that's still being evaluated. For certainly the larger tumors, fractionated approaches are probably something that we are now performing more likely than single session, just because of the improved radiobiology with fractionated treatments, usually over 3 to 5 sessions. Okay, game changer number 3, pituitary tumors. So at our center, we are very active in endoscopic and nasal skull-based approaches. So we do not offer radiosurgery up front for these tumors. In fact, radiosurgery is probably third in line, and it's for recurrent or residual tumors that have failed either 1 or 2 endoscopic and nasal approaches. But in those patient subsets, we've found that those patients do quite well, and especially in the non-functioning and functioning pituitary tumor cohorts, where we can really effectively treat and control tumor growth in those patients. And here's some data just supporting that. We're able to reduce the size of these residual recurrent tumors that fail surgery, and really control that for quite well over the long term of those patients in terms of outcomes. Brain metastases are probably our most common radiosurgical treatment pathology, and you can see here that brain mets are just quite common in the US and throughout the world. The goals of brain metastasis treatment are really, how do we effectively treat the tumor or tumors and improve function and preserve quality of life, because that's quite important, and try to get some of these patients off steroids, which can be quite problematic. We've moved away really from whole brain radiation therapy in these patients, which has become quite difficult in terms of cognitive and memory function. You can see here that the evolution of brain metastasis radiosurgery has really skyrocketed over the last 20 years. I mean, it's really the go-to choice now for patients with solitary or multiple brain metastases with really good treatment response rates in most brain metastases. You could look at different pathologies that we treat with radiosurgery, and the tumor control rate at 5 to 12 months is quite high in these patients who in the past didn't do quite as well. And some of these are radioresistant tumors like melanoma and renal cell, which respond quite well to the gamma knife. We've shown that neurocognition is actually preserved with radiosurgery in multiple brain mets that are treated. This has been shown in a randomized phase 3 study where this has been quite apparent in patients who get radiosurgery versus whole brain radiation therapy. So it's really a standard of care shift now for those patients. Now, when patients have multiple brain mets over 25 or leptomeningeal disease, whole brain radiation therapy still should probably be considered in those patients. In those patients with solitary brain mets or brain mets that are under 20 total, we can really see a rapid tumor regression when we perform radiosurgery treatment of brain mets. It's quite an attractive treatment modality, and especially in patients who are older, who have other comorbidities, and also brain tumor metastases in the brainstem. You can see here that they respond quite nicely to gamma knife radiosurgical treatment. So this is something that we definitely do on a routine basis, even with brainstem disease. We're looking at combination treatments with other types of therapies like immunotherapy. We're also looking at radiosurgery upfront, prior to resection of tumors. It seems that pre-surgical SRS may be an effective treatment option due to the better definition of the target. So the other concept that we're exploring with others is adaptive radiosurgery, where two procedures, radiosurgical procedures, can be preceded by 1 or several weeks apart from each other. This works quite well for the larger brain mets in patients who just may not be good surgical candidates. And it's a quite effective approach, actually, when we lower the dose between each of those two treatments and really see a nice response. And this works quite well, as you can see here, for these types of brain metastases, multiple brain mets that are medium and large in size. And then we provide 2 different treatments over a specified time frame, and it's quite nice. And the adverse radiation effect is lower in that way. Standard of care treatment with radiosurgery for brain mets includes the resection cavity, which has been shown to be quite effective. So we're doing that now either pre or post-surgery. Post-surgery for the cavity, pre-surgery before patients go to surgery if needed. We also have multiple clinical trials that we now have that are enrolling patients for these types of treatment approaches. But when you look at the cost effectiveness of brain metastasis radiosurgery, it is more cost effective versus surgery because these patients can go on to their adjuvant therapies afterwards. Their hospitalizations are much lower in terms of days in the hospital. These patients usually are discharged, upon their treatment, they go home. There are some challenges. I mean, we do encounter big brain mets that, either the adaptive approach or surgery should be considered. Miliary disease in brain mets patients should be treated with whole brain. And, I think, extracranial disease control really matters for patients undergoing radiosurgical treatment of their intracranial disease. So that's something that we also pay attention to and work closely with the oncologist. Game changer number 5 are gliomas. Now, we don't recommend use of radiosurgery up front for gliomas, but for residual or recurrent gliomas, especially the tumors that are higher grade tumors that failed some other types of treatments, standard of care treatments, this has become kind of a nice treatment option that we offer our patients. And I'll talk about it, shortly here, but we also combine it with other types of modalities such as Avastin that may help control disease. They're very difficult tumors to treat, as you heard from Dr. Dufault. For the lower grade tumors, I mean, I think those tumors where there's residual recurrent disease, we do consider radiosurgery in select cases, but I think those typically can be resected completely by surgery. This is a case where I'm providing in terms of a patient with a GBM. where they had a recurrence after the stoop regimen, reoperation, and then they failed Avastin, and then of course we did radiosurgery, and we had some solid tumor control for some time afterwards. Here's a dose plan for that patient with the recurrent GBM. We've been giving Avastin after SRS treatment of recurrent high-grade glioma patients who failed their stoop regimen and other treatments, and seem to have had a nice response in those patients. And that's a paradigm we've published now and also kind of adapted at our center. We feel that this may be a nice way to treat some of these patients with very difficult tumors and a terminal diagnosis. Of course, you can see here a brainstem tumor like this. This is a select case where upfront treatment, where going in surgically could really hurt this young patient. But with radiosurgery, we've had quite nice results for these types of gliomas in difficult treatment locations. We're very active in training at UPMC. We really want to make sure that we have training courses for members throughout the world. We offer these 6 times a year. Our residents are actively involved in our Center for Michigan Neurosurgery. We have teaching conferences, and we have fellows from all over the world. So, the other thing I want to highlight is the International Stereotactic Radiosurgery Foundation, where we run a lot of prospective studies in a multi-center fashion. You've seen these papers, and they're quite nice, and I think they've helped, kind of propel the field forward for many of the concepts that we discussed this morning and this afternoon. This is one of our first courses in 1995, and we've been quite active with, our training courses that we offer, and they're partly virtual now, and we even have a hands-on course for a couple of days. We had the 145th training course this last year. We've obviously had another 6 courses since then. We've done 150 total. So quite active, and we could do virtual dose planning now. So this is quite nice for training and education of trainees, faculty members, et cetera. The team for radiosurgery is quite important. We work hand in hand with the radiation oncologist. We also work closely with our neuro-oncologists, our neurotologists, medical physicists. So it's quite a nice multidisciplinary team, but the surgeon really in radiosurgery, needs to play a big part of this because of understanding the eloquence of structures, dosing, limitations, et cetera. So that's something that we've really been quite happy to provide leadership in. Going back, just to wrap it up, going back to those cases we discussed, I think this case here, we talked about the petroclival tumor. Could you do surgery for that? You sure could, but in this case, you could see here at 5 years, this tumor is shrinking down, and the effects continue to last 10, 20 plus years later in a patient who has no cranial deficits after this type of treatment option. For the acoustic, acoustic grade 4, we have follow-up now for over 25 years with over 85% local control. And you can see here, this shrank down quite nicely. So, these are quite important approaches that, I think we offer to our patients that everybody should consider. It's very important to consider these. And I think lastly, this patient I showed you before that underwent radiosurgery, complete resolution of their tumor, which was a right frontal lobar metastasis. It was an outpatient treatment, and, he got off steroids in 10 days. So again, these are things that we need to keep in mind. We have a variety of surgical expertise, but especially as we train, we need to learn these fundamental treatment options to provide to our patients, both open surgery and radiosurgical treatment. The same thing applies to, neurovascular, where we now have endovascular procedures. But I think if we could work in a multidisciplinary manner, it could really benefit our patients now that we have decades of patient outcome studies that have really established gamma knife radiosurgical treatment in our neurosurgery field. Okay, well, thank you very much. Appreciate everyone's attention.
Thank you very much, Dr. Hadjipanayis. I hope I pronounced your name right.
You did, Naren. Very good.
Thank you. That was a fantastic lecture. giving us the up-to-date on the radiosurgery from the Stella department that has pushed the boundaries positively for this area. I appreciate your time is limited. You need to.
Yeah, thank you very much. I'm sorry, I'm on call today, so
Thank you
yeah,
so much for your lecture. Much obliged. Thank you.
thank you very much. Okay.
Thank you.